I'm Jeffrey Berns, Editor-in-Chief of Medscape Nephrology. I'm a professor of medicine and pediatrics at the University of Pennsylvania School of Medicine in Philadelphia, where I'm also currently serving as the interim division chief, and I am director of the fellowship training program for the University of Pennsylvania as well. I'd like to talk to you today about the use of combination ACE inhibitor and angiotensin receptor blocker, or ARB therapy, in patients with kidney disease. I'm sure many of you are aware of the so-called Cooperate study that was published in Lancet in 2003, in which patients with non-diabetic kidney disease were randomized to receive an ACE inhibitor, an ARB, or both. And in that study, there was about a 60% reduction in the endpoint, which was doubling of serum creatinine or end-stage renal disease requiring dialysis or other renal replacement therapy. I think this trial really spurred the use of combination ACE and ARB therapy in patients with glomerular disease and other kinds of kidney disease. It certainly did in my practice and the practice of my colleagues here at the University of Pennsylvania. Other studies have really only looked at what I might call a surrogate outcome of proteinuria. There's in fact been two recent meta-analyses published just within the last year with about a dozen or more studies in each meta-analysis coming to the conclusion that combination therapy did in fact reduce proteinuria more than either an ACE inhibitor or an ARB alone, but there were no long-term outcomes as were observed in the Cooperate trial. As you may know, there's been at least two publications that have raised concern about the analysis and interpretation of the Cooperate study, so we'll have to wait and see how that all develops. In the meantime, a paper was published earlier this year in the New England Journal that was called the On-Target trial. This was a study of patients with vascular disease or high-risk diabetes looking at, again, the combination of an ACE inhibitor alone, an ARB alone, or both on the effective outcomes, mostly in the primary analysis that was published in the New England Journal on cardiovascular outcomes. The study found in a large population that there was no benefit of combination therapy compared to monotherapy, but the adverse event rate was statistically significantly higher. And then more recently, just last month in Lancet, a renal outcomes study from On-Target was published. And in this study, they in fact found that the renal endpoints of doubling of serum creatinine, end-stage renal disease, or death was statistically significantly higher in the patients that received combination therapy. There was also statistically significantly higher incidence of hypotension, which may have been a contributing factor. Interestingly, in all groups really that were analyzed, there was either a statistically significantly worse outcome or a trend in that direction, including patients with or without proteinuria, with and without diabetes. And even acute dialysis was more likely in the group of patients with combination therapy. So this study has certainly caused me to rethink what I do in my own practice. I wonder whether ACE inhibitor or ARB monotherapy or combined with spironolactone might be a better way to go. I'd be interested to know what you think about this study and whether its findings might alter your clinical practice and perhaps re-examine which patients, if any, should be receiving combination ACE inhibitor and ARB therapy. I'd encourage you to use the Medscape discussion board to comment upon my blog and these papers.